So, good evening, all present here. My name is Anurag Srivastav. I work as a general manager for Altius Biogenics, and on behalf of Altius, I welcome everyone for this extravaganza, which we are going to do it on every second Friday of the month. And today, I have honor to open the session, and I would like to thank Dr. Hema Tharoor ma'am for giving her precious time and making this program possible for us. So thank you very much, ma'am. And now to start the session, I will try to introduce Jyoti Shetty madam, whatever best possible way I can. So ma'am, Dr. Jyoti Shetty, currently working as a professor and head Department of Psychiatry, Bharati Vidyapeeth University and Medical College, and also Bharati Hospital Research Center, Pune. Ma'am is currently president of IPS Pune branch, currently president of PPA and past president of IPS Pune branch 2016-17, and Madam is a member of Institutional Ethics Committee of Pune branch. It was in 2015-16. So, ma'am, I think I'll just hand over the session to you, and thank you very much for giving this opportunity to RTS. Over to you, ma'am.
Thank you, Anurag. Good evening, everyone, and I welcome you all to the first of the academic series by the Pune Psychiatric Association and the IPS Pune branch. We have named it Cyber Gyan. This is going to be every alternate month on the second Friday at 9 p.m. I think we had the first session of the PP and IPS Pune in the second Friday of January.
Yes.
And that has been called Pearls of Wisdom. So this will be purely academic. So we'll be having 6 academic sessions every other month. So the first of the series, we are going to go back to the basics, that is schizophrenia. Before I start, I would like to say that we dedicate this session to Dr. Sarda Menon, who we lost last year at the end of the year at the age of 98. She was the first woman psychiatrist, the founder director of SCAF, that is a Schizophrenia Research Foundation. She's been a Padma Bhushan recipient. She was a former Madras Medical Service officer. And I think Dr. Hema very aptly is a senior consultant psychiatrist at SCAF and has been working there for several years now. So coming to the chairperson, today's chairperson is our very own Dr. Vasudev Parlekar, and he's a senior consultant of psychiatrist from Pune, and I don't think he really requires too much of introduction. Very well known with a lot of research to his credit. He's passed out from the BJ Medical College, MBBS MD. He's done his BA PhD in cultural epidemiology from the Swiss Tropical Institute, University of Basel, Switzerland. He's been active in the fields of research, training and practice for over 38 years in the context of state mental hospital teaching institutes and private practice. He's been my teacher. He heads the psychiatric unit of KEM Hospital Pune and is the principal investigator on several projects at the KEM Hospital Research Center Pune. He has over 35 publications and, more importantly, is regarded as a member by many students of clinical psychology, especially for, and psychiatry, of course, especially for culturally appropriate counseling. Reviews by patients value his person-centered work with genuine interest. And I will hand over the session to Dr. Parlekar from here.
Thank you, Jyoti madam. It was a very generous introduction. We are all privileged and have the honor to have Dr. Hema Tharoor with us, a senior psychiatrist from SCAF, who has had several awards. Prestigious
think, sir, signal.
Contributed to other awards.
I think sir has lost.
Yes, yes. Sir,
Okay.
ma'am, you can just.
Yeah. So, I mean, is he coming back or should I just introduce him?
He's back. I think his signal is back.
Okay.
I'm sorry if there was some technical glitch. I'm saying this will be a treat for us to have biological approaches and psychosocial approaches, seeing them coming together in difficult to treat schizophrenia. And she has over 40 publications in international and national index journals and co-authored several chapters in books in various textbooks of psychiatry. Madam, over to you. And we are very honored and privileged once again to have you here on this very important topic. Thank you. And we also thank the organizers, Anurag and Jyoti and Swati. Over to you, ma'am.
Thank you, sir. Just a minute. It's visible?
Yes.
Thank you very much, sir, for those kind words. And I think when Dr. Shetty invited me, it's like literally coming home. I've known her for so many years that it's always a pleasure, and I always look forward to my associations with her. So once again, thank you very much for inviting me. And I think I know it's a Friday night, it's 9 o'clock, and I hope all of you have had some dinner. And I thought in the next, half an hour to 40 minutes, I'll highlight practically what we would see in our clinics and how we could best manage and what we need to look out for in schizophrenia. And I think what will be interesting is we could sort of take more of audience's questions related to this because it's a very, very, sometimes the scenario. So I'm going to do a case minute format so that it's more practical approach to dealing with this illness. I want to start off by saying that I think the biggest difficulty is the challenges that we face as psychiatrists. With due respect, sir, I think, I mean, the collective age of all of us, no, put together, sometimes it's a big dilemma. We have now the latest kid in the block, Capriacin, and in spite of the carispec molecule here, as we know it as Chairperson, old is gold. Sometimes we just want to, nothing like a haloperidol, nothing like a trifluoperacin. So there's always this, how do you choose the antipsychotic? Our training, what we know from clinical practice over the years. Sometimes the guidelines, so many guidelines say so many things, and what do you follow? When you see somebody in the clinic with schizophrenia, especially, do you start monotherapy or do you start off with polytherapy? Many a times, I think over the years, what SCARF has taught me is sometimes the patient just has OCD, which is misdiagnosed as schizophrenia, and maybe sometimes OCD with poor insight. So a lot of time it's a diagnostic issue also. And many an occasion you're dealing with single episodes, multiple episodes due to various other issues related to stigma, non-adherence. And then nowadays, over the years, it's more about tolerability, individualized treatment. A lot of female patients are very clear that don't give me a drug which causes amenorrhea. So, and we know all our drugs do cause that. And thanks to Dr. Google, I think it has created more difficulties in treating schizophrenia. I want to throw this surreptitious medicines. I know that in clinical practice, we end up seeing, sometimes we don't get to see the patient. And now with the new mental health care bill, it's like we are like, you don't know, and sometimes you have to, I want to discuss that, because sometimes you have a highly agitated patient. I know the mental health bill provides provisions to for the admission, but sometimes what do? You sort of start the surreptitious treatment, and that also becomes a dilemma for you, because you don't end up seeing the patient at all. So I'm going to the few minutes that I have with all of you, I'm going to present about 7 to 8 clinically tough people. And I want to share experiences from SCARF, and I think over the years what I've seen, and I would sort of look forward to reactions from all of you. So I want to start with our traditional first episode psychosis. But what is difficult in FEP, which is schizophrenia like, is what we see is sometimes prodrome, no clear, maybe some hallucinations, but you have depression, anxiety, academic failure, obsessive slowness, posturing, poor radial. There'll be some treatment for brief period of antipsychotics. It could be an inadequate trial. uh, I want to put forward to the audience is to initiate clozapine as early as possible. There's always across India, there's data to show that clozapine initiation is always very much delayed. So you meet somebody like this, don't wait to start clozapine and go with the standard thing of giving adequate trial, 2 trials, 3 trials, ECT, and by then again, some more years is lost. So this is one scenario where you would immediately initiate clozapine. The other scenario is where you have a young male IT professionals or people who are very clear they don't want to be drowsy. And many a times, again, choosing an antipsychotic, when you choose, like an amisulpride in first episode, you have to add on benzodiazepines to help them with the insomnia and agitation. And many a times the sexual side effects are never asked. Okay, so I would place here that all of us as psychiatrists must ask for sexual side effects, because if you don't ask, they don't tell. The stigma still exists. Because they feel shy, they don't talk about it, and compliance is a huge issue. And then there is also this whole gamut of people with whom sometimes in the first episode itself you must think of depot if you're very, very clear that there is evidence to say non-adherence. So I wanted to present first episode where it's difficult when somebody presents like this, where you have to choose. If it can be a shared decision making, it can be individualized, look at the age. So I've put a photograph of a male. So what if it's a female? If it's a female patient, then please discuss with them about amenorrhea, about side effects, because many a times the amenorrhea starts and then the patient just stops the drug completely. So why is the delay very, very important? Is I just want to emphasize data here that people who have received clozapine within 2.8 years of the onset. So if you look at people who have been delayed, they had a treatment response of 81.6%. And those who, like, that is, if you go beyond 3 years, there's highly chance they become TRS. And if they got clozapine within the 2.5 years, and also received ECT, much, much better response. So this is very, very important to keep in mind the time duration. What is an unmet need, especially in first episode or otherwise in schizophrenia, is we don't have drugs that improve cognition, negative symptoms. Like I talked about TRS, other options, safety profiles, and do you have a drug that increases compliance? So having talked about first episode, I want to jump to negative symptoms as the next patient. So classically with negative symptoms, what's important is you need to recognize its negative symptoms. You need to understand, you need to do an assessment like the SANS, or whichever scale you're comfortable, the PANSS, SANS. You have even the NSA, which is a 4-item questionnaire, which you can assess negative symptom. Here, I want to highlight that for negative symptoms, we don't have a drug that is of course, the rule of thumb is we try antipsychotics, but I just wanted to highlight work from SCARF, where we looked at N-acetylcysteine. It's again, antioxidant. We went up from 1.2 gram to so there are studies that talk about up to 3 gram given in Australia. But I must emphasize here, please give for minimum 6 months. The medication is available as 600 mg, and sometimes people order online a 500 mg tablet. Just make sure that you give at least minimum 1.2 gram. You can go up to even 1.8. If you have substance use, if you have somebody with cannabis, you can go up to 2.4 grams. So in this carb study, we used amisulpride. People who are maintaining, that is maintaining in the sense they were on amisulpride or clozapine on a regular dose. So clozapine about 300 mg, amisulpride 300 mg, maintaining on that status quo, had significant negative symptoms, gave them NAC. And this study was published after 6 months of and followed them up. But I have them followed up now close to a year and a half. And I've had instances where family members have come and said, even if you forget clozapine, it's fine. Please write the NAC in the prescription. Because, and again, in our homes, I've had a family member who said, after you gave her NAC, she made a very nice potato fry. So it's about negative symptoms improving, homemaker cooking. So you could elicit this across your OP and find out if you didn't even have time to doing the rating scales. Additionally, in this thing, I wanted to talk about this data on minocycline. In my liaison with Dr. Venkatanaman, he used to tell that if you can do a CRP level, if CRP level in people with negative symptoms is high, then give them minocycline 100 mg twice a day for 2 weeks. So like I'm just reiterating, please recognize negative symptoms. It's difficult again to treat. Assessment and management. Assessment if you have the time in your busy OPD, but you could also ask at small pointers from the family, like I talked about the potato dish. I just want to spend a minute on this new kid in the block, Chairperson. It's just 3 months plus old in India. There's a lot of noise about it. Too early to comment on its efficacy. But there's a lot of literatures talking about it's, again, weight neutral, very good in negative symptoms. We've been using it quite a bit in SCARF. Initial responses, I would say, for negative symptoms, especially for the schizo-obsessive group, and seems promising. It has the same profile of aripiprazole. And just watch out for constipation if you end up combining it with clozapine. So that's the initial feedback I can give about the drug. Like I said, antioxidants, I talked about NAC, so I won't waste time here. There's even Cochrane review to substantiate about NAC. So when you're looking at negative symptoms and managing it, I know as a postgraduate, I remember giving SSRIs, methylphenidate. There's been literature with glycine, biopterin, lamotrigine. All this is inconclusive. Memantine added on with risperidone. I talked about minocycline, and there's some newer drug like roloperidone, which has not yet been released. A lot of emphasis on neuromodulation these days, about giving RTMS, and again, very specific in terms of giving RTMS or active, transcranial direct stimulation for negative symptoms, with talking about superior response rates. So if you are in a clinic where you have facilities for these neuromodulation, why not use them for negative symptoms? Psychosocial is a big onus in SCARF. We emphasize on this, improving psychosocial intervention, social skills training, and there is an efficient program in place with cognitive remediation. But NIMANS and SCARF had this work with yoga. But I want to ask the audience, I mean, we have all this data, but it's very hard, very difficult when you tell patients exercise, go for a walk, go for yoga. They look at you, there's no reaction, and the families finds it very difficult to get them to do any form of exercise. But just wanted to present evidence to say that if you gave add-on yoga, there was a greater improvement in negative symptoms. There has been also evidence to say that oxytocin, which is a pro-social neuropeptide, is released and helps when you have exercise as a module. So to just summarize the tough negative symptom person, remember that you have to think beyond dopamine, look at drugs like antioxidants along. I'm not saying ditch the antipsychotic, but I think nowadays dopamine, glutaminergic pathways, glutamate is here to stay. So it's high time that we thought beyond that. I want to present a case minute third where you have people with schizophrenia with diabetes. So again, this is somebody who came to me with schizophrenia, with insulin-dependent diabetes mellitus. She was unmarried. She did extremely well on Clozapine 200 milligrams. This here I want to stress about the significance of liaising with specialists. Please liaise, especially when you have medical comorbidity. And she again around this time when she met me, she had started reporting of voices, and she was augmented on with amisulpride, and she showed a good response on 800 mg amisulpride. And again, sugars were monitored, controlled. And then the same person, so what I'm trying to highlight here is somebody who is, we know the golden standard is clozapine, but sometimes people are resistant, reach a point with clozapine, and they still have symptoms. Then you can sort of augment them with drugs like amisulpride. And somebody like this then ended up, the same person, I'm just carrying on this and saying that she had an unplanned pregnancy. And during intrapartum, she again relapsed because they stopped the drug abruptly. And then, see, today there's no data on safety of amisulpride. But again, work from Australia, Dr. Kulkarni's group, everybody suggests that, yes, we explain the risk benefits to them, but you want to control the symptoms, it's ideally advisable that you start. So I put her back on amisulpride clozapine combination, had to give her lorazepam, liaised with the OBGYN, and I continued. So there are latest research from the Gulf area about giving clozapine. See, if you look at classic guidelines, clozapine and breast milk, people say it's contraindicated, but nowadays even that, where if you liaise with pediatricians and they say continue to give it, you have to monitor the neonate is what is ideal. Please document it, explain to the family. I did continue clozapine postpartum and she's doing well. So I just wanted to highlight how it's very difficult when people present sometimes with pregnancy. And the golden rule stands among the FGAs, trifluoperacin is the safest. Among the SGAs, olanzapine is the safest. And to keep that in mind. And again, I just put up the slide that we need to know about the risk benefits of the drugs. This is again an interesting where postmenopausal women meet us. We know about estrogen, low estrogen levels and psychosis, but what I wanted to highlight here is experience with SERM or specific estrogen receptor modulators like raloxifene, very effective. There's even studies talking about estrogen patch, how the low estrogen levels in the women could be the major cause for this. And this, again, we had somebody with treatment resistant, postmenopausal, presenting to it, all drugs tried. There was no response. And then she responded extremely well with the trial of raloxifene. It's available as 60 milligram tablets. I remember we giving her up to 120 mg. And there have been reports from NIMANS with younger women. I know there's a case report in a 24-year-old with raloxifene too. So I just wanted to present here where in a specific scenario like this, where you could think out of the box, you could think of raloxifene in a difficult to treat. Want you all to remember that when you all are thinking of raloxifene, you need to monitor. There are, again, drug-drug interactions, looking at risk of DVT, monitor bleeding time, clotting time. All this was done. So to just make sure that, you look into this. This is a big problem, very, very difficult. You'll have people coming to you not at 15, sometimes at 30. The onset starts with a lot of compulsiveness, watching, checking, psychosis now for a long duration of time. And very, very often, patients like this come, they sort of present as maybe you would also look at premorbidly introvert, some spectrum features, or sometimes the decline is with OCD and then schizophrenia. There, a combination of aripiprazole with clozapine, again amisulpride, role of SSRI very, very important, and fluoxetine and fluoxamine. I mean, a lot of us, I do sort of prescribe fluoxamine with olanzapine in cases like this. And I remember during my interactions again with Dr. Venkat Subramaniam, him highlighting how SSRI, clozapine, and they've published these papers where, in fact, metabolic syndrome, risk of metabolic syndrome being reduced, the role of obesity being controlled, the fluoxamine, fluoxetine with clozapine. So just to remember that this is another very, very difficult to treat. The other case when and very, very important is cannabis and schizophrenia. It's very hard nowadays. Cannabis is your new normal. You have patients telling you that, hey, can I take the weed along with the antipsychotic? I'm talking about not just drug induced, post that, where you've established schizophrenia, the negative symptoms, compliance, very, very hard. And it's so difficult to get them to be compliant in this group. Since I've sort of here, I just want to reiterate that the NAC dose in somebody like this should be 2.4 gram, and very, very useful for the cannabis and for the negative symptoms. Treatment resistant schizophrenia, very, very, so very important to recognize what is treatment resistance, a combination of what I said in positive, negative, and cognitive symptoms. To be more specific, please check if when you see somebody and before you call them treatment resistant schizophrenia, see if there's an adequate trial, if there has been an adequate response, and actually is this pseudo resistant? So is this schizophrenia? Is there comorbidities? Is there compliance issue? Was there a sufficient dose achieved? Sometimes duration, did adverse effects, mask the response? Please look into that. There's this whole concept of clozapine resistance, and people talk about 350 nanogram per ml dose. I know many of us, there's no lab. I think there's one lab that measures, routinely it's not done, but just wanted to put it up. ECT augmentation, ECT, there's a whole lot of stigma, and we need to, of course, in SCARF, we give it routinely, but I'm just saying patients still sort of protest about ECT. I just wanted to say about amicus, which I mentioned earlier, somebody who's clozapine resistant because due to side effects or you've plateaued with the clozapine dose, you can augment with amisulpride. That's the trial. And clozapine therapy, remember, you should give at least for 3 months to attain therapeutic blood levels. Wanted to just put a highlight on spectrum and schizophrenia. We see a lot of that nowadays. Compulsive talking to self, or is it hallucination? So many a times, I've had sometimes where we've admitted people with very distressing, they're talking and they're able to tell you sometimes they're hearing voices. Just wanted to highlight the big role of SSRIs here at an anti-obsessive dose with the antipsychotic, and aripiprazole definitely being a good responder here. And now that we have Chairperson having around the same kind of picture, to even think about that maybe in the future. Wanted to talk about case minutes related to side effects and hyperprolactinemia as very difficult to manage sometimes. So here I wanted to talk about is when you have somebody with hyperprolactinemia, the routine thing that people do is rush to the other specialist, a scan is done and everything else is sometimes, the prolactin levels are done, MRI is insisted, and then they get so scared thinking there is microadenoma, and finally they come to you. So you must ensure that when you have hyperprolactinemia, how do you sort of manage it? And if you have a drug in which they've responded to, sometimes, again, that's difficult to tell them. And thanks to Google, they're even scared. So before you switch to another drug, what do you need to ensure? Wanted to say here that clozapine with amisulpride, or if you have some, again, somebody develops this hyperprolactinemia, remember the first thing is to add aripiprazole that can reduce, especially in people who have a good response to this combination. Otherwise, what do you do is you reduce the dose. So you reduce risperidone, add aripiprazole. Sometimes if this galactoria, which is very, very upsetting, and stop at risperidone, which is mostly the offending agent, add gabapentin, sometimes bromocriptine, but keep in mind it can worsen psychosis. Sometimes there's a relapse. So what is interestingly seen and difficult to manage is you'll stop the risperidone or reduce the risperidone, you add aripiprazole, and then there's a worsening of the psychosis. You've controlled the hyperprolactinemia. So there, then find a balance where you add, you lower risperidone, add aripiprazole, add gabapentin, vitamin B6, and then monitor the patient. So wanted to highlight this also, long-term effects of prolactin. Please assure people. So this was a study where nearly 40% of men and 27% of women who were treated with FGAs for at least 5 years had normal prolactin levels. And always remember, after 4 months of treatment, prolactin reaches a stable level, which is substantially lower than at the onset. So it's very, very important that when patients receive these drugs, they develop a tolerance also to this rising effect of prolactin levels. And it's very important as us clinicians to differentiate between biochemical prolactinemia and the real. So sometimes the lab value is raised and they have no symptoms. And you must differentiate that. And they have the symptoms and the lab value is raised. So please make sure that you differentiate this. Metabolic syndrome, again, in schizophrenia, very difficult to treat. There is, again, no guidelines says that, but I've seen in clinical practice where prophylactically metformin is prescribed. There is a lot of discussions to that in giving it and saying that you're looking at weight gain and you're doing prophylactic metformin or topiramate is sometimes prescribed for weight gain. And always remember that you must monitor for sugars and obesity and, monitor lifestyle changes. So just all of us know the effects of clozapine and olanzapine and antipsychotic use in patients with schizophrenia, which is very difficult. Sometimes they're good responders to these drugs, but kindly monitor them regularly. Guidelines talk about initially baseline ECG and, fasting lipid profiles, again, monitor the sugars and then do it monthly or every 3 months. But at least depending on the socioeconomic status of the patient, baseline and once in 6 months, once a year, at least definitely monitor your patients. Other dilemmas, like I said, is surreptitious medication. It's a real huge bag. I must confess, about 30%, right from a young patient to an old patient. And now thanks to COVID, patients are, of course, we have telepsychiatry, but sometimes it's very, very hard. They're difficult. Maybe they don't require admissions. So yes, our mental health care bill is very clear. They don't talk about surreptitious, but they always warn us that if it's the patient's right here. And so we have to sort of validate that. But I must confess that when you have a family member in front of you who's extremely distressed, have I prescribed? Yes, I documented, ensure it. I sometimes give the prescription in the family member's name, telling them that because I haven't seen the patient, I talk about the mental health care bill and say that to continue to do it surreptitiously. I would like a discussion on this. Depots, again, SGA and FGA equally effective. There is, whatever said and done, the only difference is the side effects. But it'll be interesting in the next 2 years or so when we have the once in 3 months long-acting paliperidone, or when we get aripiprazole, that would be interesting when we have just a drug to be taken once in 3 months. Stigma is huge, and I think when we say difficult to treat, other than biological, and I think Sir alluded to psychosocial, I think unless we eradicate stigma, it's really, really a big challenge and dilemma. And the stigma related to ECT, and I'm tired of saying that ECT is nothing like in the Hindi movie or in the Tamil movies. and still patients don't believe, the family members don't believe it. Just wanted to give you all a snapshot of new doses, new molecules that are in phase 2, phase 3. They're all numbers right now. ALKS, ABN, LU-AF, all this in phase 2. There's a talk about a risperidone implant. Risperidone, again, once a month formulation. So we'll see when it gets here. Just wanted to put it up here. So just before I wind up, wanted to highlight again, stigma, impaired insight is an issue, substance abuse, again, violence and suicide risk. Many a times we know about, yes, we all know the drug Clozapine. And I think when extremely violent, haloperidol, I think haloperidol takes the crown. There's no drug like haloperidol and I'm eternally a fan of chlorpromazine. So I think there is a no-brainer. And often a lot of medical problems. So to keep in mind about medical comorbidity. This is a very nice snapshot. I thought if you had a patient walking into you, finally first establish if it's schizophrenia, schizoaffective. At each stage, if you look at the left-hand side corner, is there suicide risk? Is there metabolic issues? Is there violence? Is there non-compliance? Is there depression or mood symptom? Is this catatonia? We still get to see catatonia coming into SCARF. We had an NMS about 6 months ago. Again, if you don't look, you don't see it. So somebody had high fever, and now thanks to COVID, everything is COVID. But this person had a depot, high fever, CPK was very high. And then we had to, of course, we managed, again, because the person was COVID negative, refused to be taken into the general hospital. And the physician was very sweet. We sort of liaised with him and managed him in SCARF. So just wanted to highlight here that because it is rare, if you see any signs, please look at it and, think of NMS also. Again, if you look at step 3, after you critically manage it, 4 to 6 week trial of that's why amisulpride, aripiprazole, olanzapine, quetiapine, risperidone, it could be, or the older golden drugs like haloperidol, chlorpromazine. If you don't get an adequate trial and psychosis persists, you've done for 4 to 6 weeks trial, go to another antipsychotic, adequate trial, no, look at whether you're dealing with TRS. Please watch for TD. You can go up to, I remember in my days in Manipal, we've had patients up to 700 mg of Clozapine too. Again, that was not very frequent, but anyway, when you reach 300 mg, please get a baseline EEG done. Optimize Clozapine. Think about ECT, maintenance ECT here. I'm throwing maintenance ECT in as a treatment modulation, and look at ECTs as maintenance phase 2. So to conclude, please identify treatment-resistant schizophrenia early. Do not delay Clozapine initiation. I want to say criteria and guidelines are ideal for research. In your own clinic, you must be a little pragmatic and focus on the patient in front of you. Recognize negative symptoms, think of neuromodulation, psychosocial intervention should be the key. Dr. Jyoti Shetty talked about Sharda Menon. She would always say family dynamics is very, very important. Show the patient some love. She would insist on that. I would say think beyond dopamine. I'm from Tamil Nadu. I just thought I'll end my talk with this. When the elections were around in the corner, it was anybody's game. We had all the superstars and we had these stars, I think all of you recognize. But I wanted to say, so picking an antipsychotic is like these superstars on the side. But we have to look at our perceived, what do we look at as efficacy, how tolerable is the drug, cost effective. Any drug you can't give, you have to look at the socioeconomic status of the family, previous responses to treatment. And I would advocate a lot of shared decision making. So choosing an antipsychotic, please also think beyond dopamine. Thank you very much for a very patient listening, and I'll take questions.
Thank you very much, Hema ma'am. It was a very lucid, comprehensive coverage. And I'm sure people will be wanting to have your email if they have specific and very elaborate questions. I will try and give justice to some of them in the chat box. One question here asks you about N-acetylcysteine and renal dysfunction. Should we need to take any precautions?
So to answer that, nephrologists vouch on it. Like it's a drug for pulmonologists, nephrologists, psychiatrists, now a few psychiatrists, few of us. No, I haven't encountered any. I don't, yeah.
That is important because what we see in practice is, of course, sensitizing. Somebody wants to know if symptoms of smiling and muttering to self, would you regard them as positive symptoms or negative symptoms? And which antipsychotic would you prefer?
I would first check if the person is wearing a earphone.
Okay. But
smiling and muttering, I wouldn't jump and give an antipsychotic. And of course, on a very serious note, that's what I said. Many a times it's very important to ask whether the person is, I had somebody referred to me like this. And then when I asked the person, she said, I keep telling myself, I have schizophrenia, I should take medicine. I have schizophrenia, I should take medication. And then when I went back into the history, clearly somebody who's schizotypal, it was not schizophrenia. So smiling, muttering, please don't diagnose schizophrenia immediately. Please ask history.
I absolutely agree with you, but I also understand that smiling and muttering could be confusing because they could come in the acute phase as well as in the negative state or residual state. Would you like to comment?
Yes, sir. So I'm not only thing the diagnostic validity of that. I mean, or like, let's say the specificity of that, that's all I'm saying. So it could be a hallucinatory behavior. It could be a compulsive talk, and it could be, where they are. So many a times we are taught that if we see somebody who's smiling and muttering, and sometimes people with low IQ, they're just muttering. So I think we have to look into all these factors before we jump and say it is schizophrenia.
I appreciate that. Just observational diagnosis is not enough. We must let the patient give a chance to explain his symptoms and then come to a conclusion. The next question is from Dr. Bhalchandra. He says, treatment and Clozapine resistant schizophrenia. If there are bizarre delusions, acting out on delusion, amical pride, all day post tried, yoga daily, as in rehabilitation center, insight therapy. I'm sorry. This question get on. Would you like to ask it yourself, Dr. Bhalchandra? Unmute yourself and ask.
There is one patient, sir. We have tried at almost all antipsychotics.
Maybe you should think of ECTs.
Okay. Is that okay, Bhalchandra? Let us go ahead. All right. There is a question from Dr. Rajesh Nehete. There are two questions about TRS and Clozapine. Would you please comment on the management of constipation as well as management of Clozapine-induced gastrointestinal hypomotility? Significant problem in the Western world.
Yes.
Observation.
So constipation is not something that you can ignore, and you're right. In fact, I had somebody who lost his life. I mean, I had a family who came and met me because I think the patient developed even paralytic ileus, which went unrecognized and passed away. So constipation, definitely, even though we have nowadays you help them with you sort of advise fiber diet, and you do the other measures to relieve them of the constipation. Ideally, cut down on the dose, go down to a lower. That's why I said tolerability is very, very important. And constipation is a very, very difficult side effect to manage for the patient and for you. So, and patients are extremely distressed. And if they are negative symptoms, they don't tell you. You have to ask about constipation. So please, so rule of thumb, you can keep more than 2 days. If they've not passed, it's a highly advisable that you tell them to sort of reduce the dose, take care of the constipation, and then maybe switch if they're not tolerating. So I would switch and not continue the patient if the constipation is severe.
Madam,
Low
would you
dose.
Sorry.
And try augmenting with amisulpiride. Like look at other strategies of augmenting. Somebody is a good responder but has a lot of side effects to clozapine. Then go down to the best tolerated dose and augment with amisulpiride, which has a renal, metabolism.
Of impulsive, suicidal, aggressive patients with schizophrenia as an add-on?
Impulsive, aggressive in the sense, see, if you're talking about, see, sometimes you may need to add a mood stabilizer. So there's a lot of thing on talking about where you may add valproate, lithium. So you also sometimes have an overlap of, that's why I said the personality, and sometimes the aggression is not to do with the schizophrenia.
Then in that case, mood stabilizers should be more effective, right?
Yes, yes, sir.
Okay. And there was one question about fast metabolizers. Even over 800 milligrams of clozapine does not achieve therapeutic plasma levels. How do you deal with such a situation?
Then I think, see, because you can't, if you're saying that you're not achieving it in much higher dose with the risk of agranulocytosis and everything, then like I said, think of amisulpiride, go down. I mean, so you acknowledge this person is a fast metabolizer and do the augmentation. Think out of the box, think of VCT, think like that.
Yeah. There's another interesting question which perhaps relates to the area of interest that you discussed. Unknowingly giving syrup risperidone 2 milligram to patient mixed in food, of course, who is reluctant to take medications. Is it necessary to give anti-Parkinsonian drug along with it?
So even though I was taught to never give prophylactic anti-Parkinsonian, when I am doing surreptitious, I definitely give, because I've not seen the patient. I don't want the patient developing dystonia. And remember, this is a family member reaching out to you. And many a times, what guarantee that they will give that correct 2 ml or give? So I always give. So if you're asking me, yes, I always give the anti-Parkinson.
That's a practical on the ground suggestion. Thank you. Treatment and clozapine resistant schizophrenia, bizarre delusion. Oh, we covered that.
We covered that, sir.
Yeah. Whether ECT is effective or clozapine is effective in treatment resistant schizophrenia. Any comparative studies?
No. See, the gold standard, the only antipsychotic that is efficacious in TRS, established after all, is clozapine. So you are augmenting, you are saying somebody with TRS on clozapine is still showing symptoms. So I am what is across studies and everything is to augment with ECT and think of maintenance ECT as an option. So I have few patients in SCARF that we're doing that with excellent response. And again, there's no guidelines for you to say how long, when. So you can start off with even weekly initially for 3 months, then, fortnightly, monthly, and it's very individualized.
Individually tailored.
Yeah.
Another question, patient refuses to take treatment, you start depot, side effects and doesn't take Pacitane and active symptoms and difficult to wait for 3 months, no relative available for admission with patients, especially in females. Common problem, how to help?
See here, sometimes you also have to be very, very practical. So you document all this. It's a very good refuses to take, you can't, side effects, doesn't take Pacitane. You tell the family unmanageable, use the mental health care bill guidelines and do the involuntary, and then
Yeah.
you can't. Yeah.
Another question from Dr. Vinod Chaugule, a very senior psychiatrist, my teacher actually. He's asking you any specific electrode placement recommendation for TDCS, please. Transcranial direct cerebral stimulation.
Yes, sir. I mean, there is the whole positioning in the left frontal cortex. In fact, I think a few weeks ago when I had an opportunity to deliver on negative symptoms, I had somebody from Ranchi talk about where they're looking at cerebellar placements and, so there are, I can, if you can share my email ID, I could forward articles to that effect.
That would be great. Is there different placement for different symptoms?
No, nothing like that. Not for different symptoms, but for negative symptoms at this frequency, if it is tried and placed at this area of to basically, left prefrontal cortex, the area, and at this frequency it works. So that all that data is there, sir.
Any extra risk when ECT is combined with Clozapine, ma'am?
Delirium sometimes, just keep a watch on that. Yeah.
Okay. And how is injectable olanzapine short acting for managing aggressive symptoms? Your experience?
I like I said, nothing like haloperidol. Why waste in olanzapine?
Understand.
Yeah.
Ma'am, if schizophrenia patient comes with severe catatonia, normal CPK, should we stop antipsychotics? Will antipsychotics worsen acute non-malignant type of catatonia?
So, if a schizophrenia person comes to you with catatonia and you first see if this is catatonic schizophrenia. So you are going to give lorazepam up to 10 mg, do that 10 to 25 days, and immediately plan ECTs. So the other thing with the scenario where you're saying that, because you said normal CPK and has all these antipsychotics, depending, so immediately you give the lorazepam, think of ECTs is what I recommend. Schizo obsessive should be decreased clozapine or olanzapine, can SSRI. Yeah, so like I said, as a person with schizophrenia with OCD, unless you have a temporal relationship that
Dr. Rajendra Singh, please mute yourself. Yeah, thank you.
You have a definite temporal relationship to say that the olanzapine, you started olanzapine or clozapine and then the obsessions worsened. So always remember, you can have obsessions before schizophrenia, you can have during the illness, it could be drug induced, or it could be just part, like I said, somebody with schizotypal and then goes on to have, so like that.
True. And lastly, any role of ziprasidone in negative symptoms in chronic schizophrenia?
So here I could, the only time is a few patients who are like, let's say, who are very, I mean, again, who are very particular about obesity, and this is the only drug that, now, okay, Chairperson is being talked about like that, but not in negative symptoms. Again, with schizo-obsessive people, and you must see, ziprasidone is a 5-HT1/7A antagonist too. So if you can prescribe a dose of 180 to 240. That is what you should keep in mind. Then we have seen improvement in schizo-obsessive people, and that's been very few. Again, the cost and all that. I think somebody has mentioned, I'm sorry, pardon me. It is the act, not the bill, it's the act. Pardon me, Friday night.
That's okay. That's okay. Let us take a couple of interesting questions. What is the maximum dose of clozapine that can be tried in a young female non-smoker patient before we consider treatment resistance?
Again, see, the rule of thumb is if you can. So I remember there was one lab where one lab in the sense somebody sent the blood level from Chennai. We sent it to Hyderabad, and non-clozapine levels were measured. So it's 350 nanogram. If you can achieve that level, and please give clozapine for about 3 months. See, the point here is to watch for the tolerability, increase the doses, and it's the blood level that sort of tells you is the dose adequate. So yeah.
Mm-hmm. And are the two terms the same? Difficult to treat schizophrenia and treatment resistant schizophrenia?
No, they're not the same. Difficult to treat could be your difficulty, patient's difficulty, and so many difficulties open to interpretation. Treatment resistant schizophrenia is very clear. The nomenclature is very clear. We all know what we are talking about.
Yeah. And lastly, are there any studies on gene expression in peripheral blood that could be a marker for schizophrenia?
There have been reports of looking at gene, especially now with fibroblasts and offhand I can't remember the work, but I know there have been.
We'll be in touch and we can write to you always.
Yes, sir.
Thank you so much. Thank you for all the on the ground answers, ground reality answers, along with the backed by the best academic background. I thank you everyone. Thanks the organizers, Jyoti ma'am, Swati ma'am. Please take over the vote of thanks and all those things. Summary, take home messages.
Yes. Yeah. Thank you very much, sir. It was very succinct. Thank you, Dr. Hema Tharoor. I think the way you presented it, yes, it was difficult to treat schizophrenia, and I think the case vignettes were aptly sort of summarized in terms of what are the cases that we come across. It was very practical, as Dr. Parlikar said, in terms of the cases that we come across and how to treat them. I think there has been a lot of new learning for us in terms of initiating clozapine. I think when we talk about clozapine, it's always like, okay, it's a gold standard and it is something that you do last when you have finished all the trials of the known antipsychotics. So as you said in the first case itself, that probably when you have a certain symptomatology, initiate clozapine. Another learning point for me was actually continuing clozapine postpartum despite the guidelines and what. So I think, as sir said again, you're speaking from the ground and after so much of years of practice and in an institute which actually has such a load of patients. So it was really good. And apart from that, I think, yes, we would really look forward to, I think we were part of a lot of trials in the past. I think Abilify depot, that's aripiprazole depot, was an extremely promising depot. So hopefully we get that sometime in the future. And with regards to, I think the case vignettes sort of covered almost all that I had in mind in terms of the area of difficult to treat schizophrenia. If there is any questions, I think we can always talk to Hema back at any other forum. It will be very good to interact with her. And definitely we'll share across the groups her email ID. In fact, I would request Dr. Hema to probably, put it on the chat box. If anyone is interested, they can probably, sort of contact you. If there are no further questions, thank you very much again, Dr. Parlikar, Dr. Hema Tharoor, for coming on our invite and, sort of starting the proceedings with such a great lecture. Thank you very much. I will now hand over to Dr. Swati Joshi, the IPS Pune President, for the vote of thanks. Thank you.
It was really a wonderful session. I think it has cleared many doubts which will help us in our clinical practice. I think most of the things have covered very nicely. I thank Dr. Hema Tharoor for a wonderful and insightful talk. I also thank Dr. Paralekar sir and for chairing the session, and Jyoti Shetty for moderating the session. I also thank all the participants who have joined the session and all the participants who have joined the session, and also the IPS for giving the support to organize this session. Once again, thank you all and have a wonderful weekend ahead. Thank you.
And we'd like to thank Altius actually.
Yeah,
Really, Anurag has been really very nice. Until the end, he's really supported us. Thank you all, and have a very good night and weekend. Thank you, sir.
Thank you. Good night.
Thank you.
Thank you,
Bye.
ma'am. Thank you, ma'am.
Sir,
Thank you, sir.
Good night. Good night.